All right, good afternoon, everyone. This is Katie Kopp. It's 2 o'clock, so we will go ahead and get started. Just wanted to go over a few housekeeping items. So I have put everyone on mute just to reduce the background noise, but please feel free to unmute yourself at any point to ask a question or share a comment. You can always do that by pressing *6, and that's also what will mute you back. You can also always feel free to use the chat box as well. I'll monitor that for us. And so we do want to learn from everyone, so please feel free to share your wins and challenges. I also want to remind you all of our key driver diagram for the NAS initiative. Hopefully you're all pretty familiar with this, but I think it's just a good reminder to think about what we're going to be talking about today and where it fits in with the micro lessons and the interventions that we have laid out here. So we're going to be talking about breastfeeding today, and so for this month, if you're following along with the GaPQC micro lesson plan, that will be lesson 15 that'll go along with this. So now I want to introduce you to our speaker today. It is Claire Eden with the American Academy of Pediatrics Georgia chapter. Claire has been supporting breastfeeding families for over 20 years and has been an international board-certified lactation consultant since 2009. She was among the first lactation consultants to be licensed in Georgia. She currently serves as the director of the EPIC breastfeeding program at AAP Georgia chapter. The EPIC program provides breastfeeding education to physicians, hospitals, and other healthcare providers across the state through a partnership with DPH. Claire serves on the board of directors of several breastfeeding and maternal child health organizations in Georgia and is currently president of the Georgia Breastfeeding Coalition. She has a varied career in lactation, working at a pediatric practice, in private practice, and at Children's Healthcare of Atlanta, in addition to the Georgia chapter AAP. She and her husband are the proud parents of 3 daughters, and her family has enjoyed putting down roots in the Atlanta area for almost 20 years. So with that, Claire, I will turn it over to you. And again, just press *6 to unmute yourself.
Katie, can you hear me?
We can hear you.
Great. So you'll be advancing my slides, right?
I am, yeah.
I'm still seeing, oh, there we go. So there's me. I have no conflicts to disclose. And I wanted to start with just, an overview just to kind of place us in context, our topic today, that NAS is a generalized multi-system disorder. Some groups are also using the phrase NAS for neonatal opioid withdrawal syndrome. And of course, these symptoms are due to the abrupt discontinuation of a chronic exposure to opioids in utero. And the incidence of NAS is increasing around the U.S., and I know many of you have seen that in your communities. So to get started, I wanted to look at our results from the recent Bondi audit of the hospitals that responded. 71% of infants with NAS were discharged home, but only 15% were breastfeeding or receiving any mother's own milk at the time of discharge. And then also of note was that only 17 of the 38 hospitals that participated in the audit, which is 45%, had a policy or guideline that encouraged breastfeeding or the provision of expressed human milk in substance-exposed infants. This is probably even a lower percentage. This 15% that were receiving any mother's own milk were also a even much lower percentage were exclusively breastfeeding at the time of discharge. So to kind of get started, I thought we could consider a few questions when you consider how this, the topic of breastfeeding is handled in your facility, first of all, does your facility have a clear policy around who can breastfeed? And I put that in quotes because that's kind of how it's discussed, from a parent perspective and also from a provider nursing perspective. So do you have a clear policy? Are your staff comfortable and clear about that policy? Do nurses and doctors and families at your facility feel like they're on the same team? Do mothers and family members feel empowered and that they're integral to their child's care? And are mothers and parents having positive early parenting experiences in your hospital when you're faced with an NAS dyad? So looking at this from a parent-centered approach, of course, the first question is that risk-benefit discussion around the risks of breastfeeding and the benefits of breastfeeding. So as a prenatal plan is ideal, and preparing the mother for parenting is parenting, breastfeeding, and substance abuse treatment should be formulated through individualized patient-centered discussions with each woman. The care plan should include instruction in the consequences of relapse as well, because when there can again be withdrawal symptoms again if breastfeeding is stopped really abruptly. And there should also be teaching regarding the potential for donor milk, formula preparation, and bottle handling and cleaning if breastfeeding becomes contraindicated. Katie, I think I missed, the slides are in a little different order. I'm not sure you have up the most recent presentation that I sent you. But yeah, the language that we use as healthcare professionals is really important. That we're consistently using language that destigmatizes addiction disorders. And this is, if you look at the Vaughan identified potentially better practices, number 3 is that we create a culture of compassion, understanding, and healing for the mother-baby dyad. And, breastfeeding is personal, addiction is personal, but they're also both medical situations that we need to look at from a medical perspective. So I think both of those are important to consider.
Hey, Claire, if you notice that I've got the wrong one up or out of order, we can pause it for 1 second and I can go back in and pull it up.
Yeah, the most recent slides look a little bit different. So if you wouldn't mind reloading from the ones that I sent you, I can forward you the email again so that you have the right version.
I should be able to pull it up. Sorry, guys. Give me just 1 second, and I'll get it changed really fast. Sorry about that.
I sent it yesterday at 12:39. It should be the version. Let me open it up and make sure.
It was probably when I copy and pasted.
Or I sent you the wrong one. Let me see. Let me compare the two. It may be that I sent you the wrong version, so let me just send it to you real quick.
Okay.
Okay. And then we can just skip. The beginning ones are pretty much the same.
Okay, that sounds good.
Let me know when you get it.
I will.
Oh, wait, it says I shared you a link. I didn't mean to do that. Can you open the link?
The email hasn't come through yet, but I'll let you know when it does.
And then we can go ahead with where we were as well while you're waiting for it.
Okay.
Let me just make sure that it got sent to you. Attach as a copy. There we go. Thank you for your patience, everyone.
Yeah, if you're just joining, we're going to switch out the slide set real quick.
Okay. All right, let me get back to where we were. And I can go ahead from here right now.
Okay.
So yeah, we were talking about the importance of using family-centered, compassionate language, and I think because breastfeeding is such a personal issue, as well as a medical issue, I think we have the double layer happening between breastfeeding being a very personal issue and a cultural issue, and also addiction. It kind of falls into a similar category. Okay, and I think we covered this about the importance of a prenatal plan. So why are we even talking about breastfeeding in this population? The most important things to consider around that are that the research shows us that breastfeeding reduces three important things. One is it reduces the length of stay for babies that are having withdrawal symptoms. It reduces the need for pharmacological treatment. It either reduces the incidence of babies that need the pharmacological treatment, or it can reduce the length of time or the amount of pharmacological intervention. And then it also can be part of a bigger discussion around the benefits of breastfeeding that are, oh look, here, is this the new one? Yeah.
Yeah, there we go.
Great.
Okay. I'll go to...
Yeah, the why breastfeed. So it reduces the likelihood or the length of time that there's pharmacological intervention required, and then it also will reduce the severity of the symptoms, which is kind of a follow-on to the requirement for pharmacological intervention. And the benefits of breastfeeding can have specific application to families dealing with opioid withdrawal. So I think it's important to consider the whole angle of which benefits can be more particularly significant to NAS infants, such as the SIDS risk is modified, infection risk of a lot of common childhood or infancy-related risks are modified. Improved maternal-infant bonding is especially important in NAS dyads, and there's studies that show that breastfed babies have a decreased risk of neglect that are important to consider. Those are benefits to all breastfeeding families or dyads, but those benefits can be of particular significance in this situation. Then, of course, we always want to consider that there are risks to not breastfeeding that we want to always have as part of a risk-benefit scenario. We can't just assume that a baby that doesn't receive any mother's milk there's risks to not receiving mother's milk or not breastfeeding. Okay. So here are a few of our sort of strategies about breastfeeding that make it important. Encouraging breastfeeding should be part of the overall treatment plan for a family, and it should be integrated into policies, guidelines, and services that your facility is providing. Rooming in, skin-to-skin, and Q-based feeding are really the backbone of non-pharmacological management of NAS, and I understand that we haven't really gotten to that part in our schedule of webinars. They'll be coming, but I think it's good to have the breastfeeding as kind of back in the back of our minds when we're considering non-pharmacologic management of NAS. And I know more and more hospitals nationwide and in Georgia are starting to use the Eat, Sleep, Console method. And I wanted to mention this because as a lactation consultant, when I read that, I'm like cheering, but I know that we also run into how this might not fit into some parenting philosophies that are very specific around not using that order, but it's a biologically sound method, and it's evidence-based specifically for NAS dyads. So we need to be aware of our own biases around that, how that connects into breastfeeding success. Okay. This is all kind of related to the idea that goes along with family-centered care and non-pharmacological management of NAS, is that the physical environment is a really important factor in the treatment. I think looking at the parents of an infant and the family members of an infant being a really integral part of that physical environment, it's not only the crib and the lights and the sound, it's being in arms. Really, all infants experience a really abrupt change in environment just by the fact of being born, right? They come from where they're getting a lot of movement and they don't have temperature changes and they don't feel hot or cold and they're not having their diapers changed and things like that. So all the things that can be helpful with that transition are even more important in a baby who needs help managing their withdrawal symptoms. So rocking and swaddling and all those kind of attempts are really there to replicate the physical environment of the mother's body. And when a mother and baby are breastfeeding, there's that reinforced regular time.
Claire, are you still on the line? Okay, I think that with the call, she might have accidentally hung up on it, so I'm going to give her a second to join back in. Okay, Claire, were you able to join back in?
Hi, Katie, can you hear me?
Hey, we can hear you.
Okay, sorry, my other phone line rang and I needed to figure out how to call back in.
That's perfectly fine.
Okay, sorry for the interruption. Let me get back to the webinar so I can see what you guys can see.
Okay.
Okay, so we were talking about the mother-infant, the mother's body being the physical habitat of a newborn infant, and how that fits in with breastfeeding. So keeping in mind, why are so few babies being breastfed or receiving mother's own milk at discharge? I want to read this part of the AAP statement on breastfeeding the use of human milk, which was updated most recently in 2012 and will be updated again in 2020. The maternal substance abuse is not a categorical contraindication to breastfeeding. Adequately nourished, narcotic-dependent mothers can be encouraged to breastfeed if they're enrolled in a supervised methadone maintenance program and have a negative screening for HIV and illicit drugs. So we're going to talk through some of the kind of permutations of that. The AAP also published a clinical report on the transfer of drugs into therapeutics in human breast milk. This was in 2013. And I pulled out some of the relevant segments. It says potential adverse effects on breastfeeding infants from methadone and buprenorphine include lethargy, respiratory difficulty, and poor weight gain. The long-term effects of methadone in humans are unknown. Nonetheless, methadone levels in human milk are low, with the calculated infant exposures less than 3% of the maternal weight-adjusted dose. Plasma concentration in infants are also low, with less than 3% of maternal trough concentrations during the neonatal period. This is where they cite the Academy of Breastfeeding Medicine policy, which our guideline. We're going to talk about their protocol. It's number 21 of their many protocols. For these reasons, guidelines from the Academy of Breastfeeding Medicine encourage breastfeeding for women treated with methadone who are enrolled in methadone maintenance programs. Transferred amounts of methadone or buprenorphine are insufficient to prevent symptoms of neonatal abstinence syndrome. Neonatal abstinence syndrome can occur after abrupt discontinuation of methadone. Thus, breastfeeding should not be stopped abruptly, and gradual weaning is advised if a decision is made to discontinue breastfeeding. So I wanted to kind of point out that I think one of the reasons that so few families are supported in breastfeeding or encouraged to breastfeed is because we feel like we don't really have all the information, or we're kind of defaulting to a better safe than sorry scenario instead of looking at the guidelines that are published. So I wanted to make sure that we're all aware of that and considering that when we're having these risk-benefit discussions with families. So in that slide, they talked about estimating the drug exposure via milk, so I wanted to kind of put some information here. Relative infant dose is what's used for a lot of risk-benefit discussions around maternal medications in general. And so that is a formula to, using how much of studies that are available to show what the relative infant dose would be of any certain medication. So in general, any relative infant dose of less than 10% of the maternal dose is considered safe. And like I mentioned, two of the main medications in maintenance programs, both of those are estimated at less than 3% of relative infant dose. So I think our group wanted to make sure that we know that many of you are dealing with families where there might be other exposures, not only to maintenance medications. So I think in the interest of time, we can't really spend a lot on this today. I wanted to keep it focused around NAS scenarios, but please know that alcohol, cannabis, nicotine, other prescription medications, those are all covered in the Vaughan micro lesson that is available to you all. It's a pretty thorough slideshow from Lauren Jansen, who's an associate professor of pediatrics at Johns Hopkins. And you can get in touch with Katie if you need help accessing that. These medications or other exposures are also covered in the ABM protocol that I mentioned, the Academy of Breastfeeding Medicine protocol. It's number 21, and that will be listed in the resource slide. Okay, so when we're having this risk-benefit discussion, we need to keep in mind this is not a yes or no or black or white scenario. And the guidelines that are outlined in the Academy of Breastfeeding Medicine protocol kind of have a pretty clear category of who should be encouraged to breastfeed or provide milk. And these would be women who meet the following criteria. Women who are engaged in substance abuse treatment, women who, and if you want to go to the next slide, Katie, I kind of have this a little briefer laid out. There we go. women engaged in substance abuse treatment who have provided their consent to discuss progress in treatment and their plans for postpartum treatment with substance abuse counselor, women who've been able to achieve and maintain sobriety prenatally, are working, with a counselor, that they plan to continue in that substance abuse treatment in the postpartum period, women who've been abstinent from illicit drug or illicit drug abuse for 90 days prior to delivery, have demonstrated that ability to maintain their sobriety in an outpatient setting. They've received maternal, they had a negative urine drug screen, and they've gotten consistent prenatal care. So that's a pretty long list, but those should be in your green light kind of category. And it should be regardless of maternal methadone dose, because as you saw, kind of the standard dose still gives a relative infant dose of less than 3% of the maternal dose. So these are from the Academy of Breastfeeding Medicine Clinical Protocol. But I think these would be your green light, but in the resources there's another perinatal quality collaborative that developed an interesting kind of like red light, yellow light, green light scenario. And so I think that there are guidelines around scenarios where we might want to consider supporting breastfeeding even if they haven't hit 100% of these guidelines here. So the thing to keep in mind is each dyad should be individually evaluated and counseled, because the other angle is what is the mother's feeding goals. Like, not every family has a goal to breastfeed, and they may want to not exclusively breastfeed. So I think it's important to make sure that we're considering the maternal feeding goals, and that her decisions around her feeding her infant are based on informed consent, especially considering the two angles of informed consent. In this situation would be breastfeeding could reduce her infant's risk for needing pharmacological treatment. It could reduce the length of stay, and it could reduce the symptoms of NAS. So that's part of an informed consent decision. Okay, so the next slide, Katie. I think the other thing to consider in this role of informed consent is the timeline. Ideally we're working with families prenatally, but we know that doesn't always happen. So keeping in mind that a mother's milk does not even really begin to increase in volume until the second day, 30 to 40 hours after the delivery of the placenta. And colostrum is very low volume, so even if a mother were to be exclusively breastfeeding in that time period, there would be very little exposure due to the low volume. And this allows time, perhaps, to determine if the diet is a candidate for breastfeeding if there hasn't been, an adequate assessment prior to the delivery of the baby. So another thing to consider is offering pasteurized donor human milk temporarily if a mother indicates a desire to breastfeed, but that adequate evaluation hasn't been made yet. One kind of caveat about offering donor milk to mothers who want to exclusively breastfeed is this needs to be accompanied by skilled assistance to express and save her milk, or else her milk supply is going to be very severely affected by not breastfeeding or not removing any milk in the early days while you're waiting to make a decision. And like I mentioned, mothers' goals for breastfeeding are going to differ. Parents in this situation deserve support for their own goals just as other parents do. So informed consent should be, critical part of any feeding decision conversation in your facility. Okay, I wanted to point out that there's a great report from UC San Diego when they updated and clarified their policy around breastfeeding and NAS. They did this in a quality improvement effort to increase the breast milk provision in their patient population. And these are some of the benefits that they saw when they updated and clarified their policy and then trained everyone on their policy. The first thing that they thought was really important was that the staff felt much less frustrated because the messaging was much more clear. The policy was more clear, the guidelines were more clear. And then when more mothers were encouraged to breastfeed, they reported that they felt more welcomed in the unit and more part of their baby's care. There were less adversarial relationships between families and staff when they clarified their policy. Mothers reported that they had a role in their baby's care that no one else could fill, and that was unique to them, and that helped them feel more engaged in parenting. Fathers and other family members and partners reported that they felt empowered to help mother visit their baby in the NICU, help them with breastfeeding, support them with breastfeeding, or to ferry milk back and forth to the unit when they came to visit from mother who was expressing at home. And then lastly, but really not least important, is that for the compliant NAS mother, breastfeeding became part of an early success and positive parental experience, which has a lot of, permutations in the long run. I really enjoyed reading about their process. So I think a couple things we want to acknowledge is that breastfeeding can be hard, and like I mentioned, it's a personal issue as well as a medical issue. So it's important that if we're going to encourage breastfeeding, we need to be properly resourced to do so. So I think part of any effort to increase breastfeeding should be an evaluation of what your current resources are. Do you have a trained international board certified lactation consultant on staff to advise the group? Do you have enough FTEs of lactation support? Are your nurses trained to help with kind of the standard breastfeeding, latching on help, and things like that? Because there are kind of three groups of challenges to lactation in an NAS population. One is, mothers are dealing with guilt, a lack of confidence in themselves as parents and in their ability to breastfeed. Many of them may have always believed that they couldn't breastfeed or they shouldn't breastfeed. Really, all new parents complain about conflicting advice, but even especially in this situation. And many of them have been victims of, many women in this scenario have been victimized in their own life, and that can include sexual abuse as well, which can impact breastfeeding. Infants who are having symptoms of NAS are hard to breastfeed. They have poor state control. They can be irritable. They can be hypertonic. They can have disorganized suck. They generally have poor feeding. So a lot of your feeding strategies that are related to bottle feeding or formula feeding are going to apply here too. Frequent, small feeds, and they need to be assessed a little more carefully that they're transferring milk well, and encouraged to have lots of skin-to-skin time to help control their state. And they may need some help from an IBCLC with helping with the disorganized suck and optimizing breastfeeding. So there are challenges there from a resource standpoint. And then providers, complain of having, like we mentioned, not having clear guidelines or not feeling as if they're educated or prepared to help advise families around breastfeeding. There's stigma around opioid addiction, and we have, as providers, many of us have biases around that. And then my day job here is helping provide education to physicians around breastfeeding, and physicians tell us that they, that they don't feel prepared to help mothers breastfeed a lot of times. So many providers themselves don't feel like they have the skills or resources to help families breastfeed. So while we want to be increasing that number of babies that are discharged home breastfeeding, we have to look at the big picture of what resources do we need to identify in our individual facilities to make that happen. So some of the keys to that, I think, that are important to consider is that first we want to develop a policy to standardize care. Consistent care is quality care, and this is the Georgia Perinatal Quality Collaborative. We're talking about quality care, and being consistent is really a critical part of that. So standardizing care, and also considering, are your policies consistent in the well baby unit and in the NICU, because you know, a lot of times babies spend time in both, or you want your staff that work in both units to be familiar with a consistent policy. Secondly, incorporating breastfeeding decision-making into your NAS protocols and bundles, and making sure that everyone is trained on what your policy is and feels comfortable with it, and that staff have time to share their questions or their concerns so that you have good staff buy-in on a policy. And part of that policy, or part of implementing the policy, can be creating a multidisciplinary team that is going to do plan, do, study, act cycles so that you can see how the plan is rolling out and measure your success. And then lastly, really integrating breastfeeding decision-making into plans for continuity of care and identifying resources in your community. The initial management and support of breastfeeding is really critical, but having the long-term continuity is going to be important too. And as the chair of the State Breastfeeding Coalition this year, I'd be happy to help identify resources in your community if you want to reach out that way. So speaking of resources, I put some together here. Like I mentioned, the ABM Clinical Protocol number 21, which is the guidelines for breastfeeding and substance use or substance use disorder. It was revised in 2015. They are really good about keeping their policies. If you're not familiar with the Academy of Breastfeeding Medicine and you work in a birth hospital, I hope you'll get familiar with their policies, because they're very well researched and they're evidence-based, and they review all their policies very regularly. And they're a great place to start if you need, you know, their list of references are a great place to start if you want to learn more about a topic that comes up often. And their guidelines are really a great way to check if your practices are evidence-based. As I mentioned, the AAP also published a clinical report on the transfer of drugs and therapeutics into human breast milk. This came from the Committee on Drugs from the National AAP. It was published in 2013. And then also the AAP statement on breastfeeding use of human milk should be kind of your standard, you know, gold standard place to go to around evidence-based breastfeeding policies in your facility. And then I mentioned these two other online resources. One is from the Northern New England Perinatal Quality Initiative, and they have published some guidelines that you can find there. And then I liked that traffic light, and I think it's a good way of thinking of things in, like, there's going to be yes cases, no cases, and then there's going to be a lot of cases in between that need that individual assessment. I don't know, you know, every facility might interpret that differently, so I don't think this traffic light is necessarily like the go-to for every single facility. You might, you and your physicians might look at things a little different, but I think it's a good kind of paradigm to use to create your own guidelines. So I have the link there for that. And then I think we have some time for some questions. I put my email here, but I think that we wanted to have a little bit of time for questions from you all.
Yeah,
I'm going to pass it back to Katie.
Yeah, thank you, Claire. That was a really thorough and helpful presentation. So like Claire said, we've got plenty of time for questions, so you can either unmute yourself to ask them using *6, or you can feel free to use the chat box as well, either one.
Claire, it's Dr. Levine. Thank you. That was a great presentation.
Oh, thank you, Dr. Levine.
Well, here's a question that just occurred to me. You know, we expend sometimes a significant amount of effort convincing moms to breastfeed who have not already decided to breastfeed. So what's the role for that in these moms?
Well, the studies show most women.
How is it different? How is it more difficult? I think
yeah,
it is.
I mean, I think most women decide if they're going to breastfeed, either before they even conceive or early in the pregnancy. And like I mentioned, I think women who have substance abuse disorders probably, are like most moms. They want to do the right thing for their baby, and without adequate education, they may just presume that breastfeeding isn't an option for them. And so that's why I think that prenatal education and the informed consent piece is really important. And frankly, that's probably really important for almost all NICU mothers. Many of them, when I worked supporting NICU families, I worked a lot with mothers who weren't planning to breastfeed, and a lot of it was based on not having good informed consent around what the benefits of breastfeeding would be for their particular situation, because in our culture, breastfeeding is sort of equated. It's like, well, this is ideal, but my life is not ideal, so it's going to be better for me to formula feed. And for some families, it will be. But I think we want to make sure to do what we can when we have access to mothers prenatally, that they're making an informed consent decision around their feeding choices.
Unfortunately, for a lot of these moms, we're not living in an ideal situation like they do in Toronto. That hasn't been done prenatally, and the first discussion of that is postnatally.
Right. Yeah. So I think being open and we want to respect mothers' choices around feeding. I don't think any of this is about begging people to breastfeed, but I think making sure that we have had that informed consent decision or discussion, especially providers. Parents listen the most in the NICU to neonatologists, in my experience. So when neonatologists make that part of their discussion with parents, I think that's one place that we can make sure that the feeding decision is informed and they are aware that it could reduce the length of stay, and theoretically, it's not going to for every baby, but if the mother's a good candidate for breastfeeding, that she's aware of those ways that it could benefit her baby. And if she says she only wants to breastfeed while they're in the NICU, that could be okay, and that there's a plan to wean off gradually.
Yeah. Thank you, Katie. Claire.
Yeah, no problem. Who else has some questions? I'm hoping that Dr. Levine and Dr. Patel could help answer them too.
Okay, we have one question in the chat box. I'll read it off. What is a good way to invite a mother who is also a smoker to perform the care for her baby, especially the extra bonding care her baby needs? And the disassociation that seems to often happen, an indicator of something we aren't getting. This refers to all care, including breastfeeding, as a good option.
So I'm hearing in this question that when a mother's a heavy smoker and her clothing or her hair and things can be emitting that tobacco smoke, that how can we encourage those mothers to spend more time in the NICU providing cares for their baby? Do you think I'm understanding the question right, Katie?
Lois, if you're able to press *6 and unmute yourself, that might and maybe ask it over the phone. I think it's maybe more about how to encourage mothers who are also a smoker.
Well, from the smoking perspective, first of all, mothers who are smoking cigarettes should be still be encouraged to breastfeed, but they should be actively encouraged to minimize, use the very bare minimum that they need to get by and reduce tobacco use as much as possible. They should be encouraged to, smoke away from their baby, outside, change their clothes, wear a robe or whatever. We've offered clubs and things to mothers who want to spend time holding their baby. Skin to skin is great, so that can just be removal of the clothing and offered, a gown or a blanket, so that we're removing some of that exposure. But I wanted to touch on what Lois talked about about the disassociation, and I think, I'm not a psychologist, but I think a lot of mothers feel afraid to be invested in their baby, and when they haven't taken the baby home, the baby doesn't feel like their baby. And I've seen this working in a children's hospital with parents of infants that were readmitted are really in a different place than parents whose baby was transferred to us from a different hospital, because when a baby's been in the NICU its whole life, the parents feel responsible sometimes. They don't feel ownership over the baby. So I like to point out how the baby is looking at the mom. Look how comfortable they look in your arms, and some of that, real just scripting. It sounds kind of stilted when I'm saying it on the phone, but I've had such good response to those sorts of praises, and giving lots of opportunities, just off, saying, oh, she likes it better when you change her diaper, or look how when you hold her to feed her, she feeds better, in a bottle feeding scenario. So those sorts of things can help encourage that bonding experience. And the great thing, like I mentioned about breastfeeding, is it puts the baby in mom's arms repeatedly, in skin to skin, and a little bit of praise can go a long way.
And Lois, I think you unmuted yourself. Did that answer your question?
Yes. Can you hear me?
Yeah, we can hear you.
Oh, okay, good. I don't. So yes, you understood my question best at the last. It seems like a little bit of a scenario too often whereby the less time they spend with them, maybe having to do with their need to smoke. Almost. The big question was how to emotionally keep a mother bonded as best we can, without pressuring her, because pressuring and being in the hospital with the NAS questions and assessments going on often seems to increase their anxiety, at least slightly, if not more, and then the need to smoke goes up, and the bonding and the disassociation tends to feel to me like a ball that's picking up speed. And I guess that was my question. What are ways that you have found to keep them plugged in? But you did answer that well with your praise answers.
And Lois, do you involve parents, mothers specifically in the scoring process?
We have very few of them. We usually give them just a very basic explanation of what we're looking for, but they are not a part of the process, no.
I mean, that's something to consider. I know it might not work in every facility, but involving parents either as one of the scorers or doing their own scoring, or making sure that they're really walking them through that process while it's happening so that they understand. I mean, the funny thing about this kind of scoring is we want, it's so many like testing type situations. People think, oh, I'm cheating. I shouldn't be told the answer, but like parents should be shown how to help increase this, improve the scores, right? Like and making that connection for them of how things that they're doing are helping with the symptoms and helping reduce the severity of symptoms, and what their unique role is in reducing the severity of symptoms. That's good. Like, we want that to happen. And I think when we talk about scoring, it kind of brings up this testing scenario that's supposed to somehow be like independent of parents, or like, they're, that we don't want them to do well. We want babies to have less severity of symptoms.
No, that's good. That's exactly right. I think you're dead right there.
So I think having your team discuss, what kind of scripting is used to have those discussions with parents and role-playing those discussions can really help standardize and then increase the quality of those discussions and that education.
Yeah.
Who else has a question? Oh, I'm sorry. Yeah.
No, I was finished. Thank you so much for addressing that.
Yeah, you're welcome. Thanks for asking, Lois. I think you asking that question, Lois, shows like how you're really in the trenches doing the work. So it's helpful when people ask questions so that everyone can learn from each other.
And just a reminder, if anyone else has a question, you can press *6 and ask it, or type it into the chat box. And while you're doing that, I'm going to pull up a different set of slides to just go over a few reminders. Okay, well, I'm not hearing any questions or seeing any, so while you're thinking about it, I'm going to just run through a few announcements and reminders, and please feel free to just interrupt me anytime by typing in a question or saying it through the phone line. But so the first announcement I wanted to make is that Laura Lane will be joining the GaPQC team on December 1st. She is essentially filling the role that Grace King was in. I know many of you worked with Grace, so she'll be taking over leading this NAS project. It'll be a warm handoff, so we'll make sure that we transition everything really smoothly and also be working on it, to kind of help Laura as she transitions. So this isn't the last call that we'll have together, but Laura's great. She is currently a Deputy Chief Nurse in our Office of Nursing here at the Department of Public Health. She has a lot of experience in QI, has a green belt in Six Sigma, and she's a really friendly and warm person, so I know that you will all love getting to work with her. And when she officially comes on board, we'll make sure that you have all of her contact information. The second thing that I wanted to announce is that we're going to be doing our second kind of QI technical assistance call on December 19th from 1 to 2 p.m. We did one of these, I think it was back in October, and it was a really great chance, I think, to go a little bit more in depth into QI. We obviously try to cover that on most of these monthly calls that we have, but this is a great chance to ask, some more in-depth questions and get help that's maybe tailored to interventions that your hospital is either working on or considering. So I'll be sending out a calendar appointment for that this afternoon, but wanted to go ahead and make a note of it here as well. Another thing I wanted to make a note of, and this is kind of a general thing, so what I have up here is a screenshot of what you should see when you log into the edX system to access the micro lessons. I'm sure most of you all are very familiar with this page. Up on the right-hand side is a toolkit. We have a Georgia version of that toolkit, and so it just has some branding with GaPQC along with Vaughn. And if you're sending this out to people in your hospital, sharing it with your team, we would encourage you to use that version. It has kind of a welcome letter and that type of thing. So the content is the same, but and also just if you weren't aware that that toolkit is there or haven't gotten a chance to read through it yet, we definitely encourage that. One more, the last two reminders that I have are, so each month I send out the, kind of progress report for how the different core team members and just all members at your hospital who are signed up to access the microlessons, how many they've watched. And I know that sometimes you all respond back and say, no, we think we did watch these. We announced this in May, but I think it's worth doing more frequent reminders. In order for it to show up on that report that you've completed the lessons, you have to go all the way to the page and access the certificate, or else it won't populate on there. So if you're wanting to receive credit for that, be sure to have everyone on your team go to that last page to access the certificate. And then the second thing, and this was my apologies, wrong information that we shared at the beginning, and I just want to make sure we have it cleared up. So in order to be the NAS Center of Excellence from Bond, you have to have 100% of your core team completing all of the micro lessons. So, and remember, you get to decide who is on your core team and who isn't. So the people who you really want to be completing all of the lessons, be sure that we've gotten all of those people switched to a core team member. And if you don't expect them to complete all the lessons, be sure to take them off of your core member list. So, and we do encourage that regardless of the size of your hospital, that everyone has at least 5 members who are on their core team. And if you're, a larger hospital, it's very likely that you would have a lot more people than that. That's just kind of a minimum number that they use. So those are just 2 things I wanted to make a reminder of real quick. And then you'll get this sent out when I send out the slide deck along with Claire's slides, so you can access all of those resources, especially that she put up there. But I wanted to just make a note of all of the micro lessons that we've given out each month to complete. I know we share them each month, which one we have you going through, but wanted to make a note of if you're following along with the GaPQC schedule, and it's fine if you aren't, that this is what we've gotten through. So are there any other final thoughts or questions, either for me or for Claire, or just for your other teams that are on the call?
Like just a sidebar when it's over or something like that, but just because I have
Dr. Levine, am I forgetting anything? Any reminders that you have? Okay, he might have needed to jump off. Well, I'm not hearing anything, and I don't see it in the chat box either, so we can go ahead and wrap up this call. But
I was just going to say you covered everything very well, Katie, and I think it was a great webinar. Thanks again, Claire.
Yeah, I agree.
You're welcome.
And everybody else.
Yeah, thank you all for making time to be on the call today, and thank you for being flexible about the date too. Our next one will be at our regular time on December 10th at 2 p.m., and we will be talking about maternal substance use and treatment. So we look forward to being together then.